USMLE style question on Chediak syndrome. Question: a 5-year-old boy is brought to the pediatrician due to recurrent bacterial infections, easy bruising, and progressive neurological deterioration. His parents note that he has been having frequent staphylococcal and streptococcal infections, as well as partial oculocutaneous albinism since birth. Physical examination reveals silvery gray hair, mild hepatosplenomegaly, and peripheral neuropathy. Laboratory findings: peripheral blood smear, giant granules and neutrophils, platelet count, mild thrombocytopenia, neutrophil function test, impaired chemotaxis. Which of the following is the most likely cause of this patient's condition? A. Impaired phagosome-lysosome fusion due to a lysosomal trafficking defect. B. Defective NADPH oxidase leading to impaired respiratory burst. C. Mutation in the WAS gene affecting cytoskeletal remodeling. D. Absence of CD18 integrins impairing neutrophil adhesion. E. Deficiency of adenosine deaminase causing lymphocyte dysfunction. Answer: impaired phagosome-lysosome fusion due to a lysosomal trafficking defect. Explanation: this patient has Chediak Higashi syndrome, CHS, a rare autosomal recessive disorder caused by a mutation in the LYST gene, which encodes a protein required for lysosomal trafficking. The defect leads to impaired phagosome-lysosome fusion in neutrophils, recurrent pyogenic infections, abnormal melanosome transport, partial albinism, silvery gray hair, light skin, defective granule release in cytotoxic T cells and platelets, bleeding tendency and peripheral neuropathy. Peripheral blood smear finding: giant granules in neutrophils due to defective lysosomal trafficking. Key features of Chediak Higashi syndrome: findings in CHS, inheritance, autosomal recessive, LYST gene mutation, pathophysiology, defective lysosomal trafficking, impaired phagosome-lysosome fusion, immune defect, impaired neutrophil chemotaxis and phagocytosis, peripheral blood smear, giant granules and neutrophils infections, recurrent bacterial infections, staphylococcus, streptococcus. Skin findings: partial oculocutaneous albinism, silvery hair, light skin. Neurological symptoms: peripheral neuropathy, progressive neurodegeneration. Hematologic symptoms: mild thrombocytopenia, bleeding tendency. Progression may lead to accelerated phase, hemophagocytic lymphohistiocytosis, HLH. Treatment: bone marrow transplant BMT is the only cure. Why not the other options? B. Defective NADPH oxidase leading to impaired respiratory burst. Describes chronic granulomatous disease, CGD. Presents with catalase-positive infections, S. aureus, Aspergillus nocardia, but does not have albinism or giant granules in neutrophils. C. Mutation in the WAS gene affecting cytoskeletal remodeling. Describes Wiskott-Aldrich syndrome. Ascot-Iscot, albinism absent, S. small platelets. Presents with thrombocytopenia, eczema, and recurrent infections, but not albinism or neuropathy. D. Absence of CD18 integrins impairing neutrophil adhesion. Describes leukocyte adhesion deficiency. Presents with delayed umbilical cord separation, 30 days, recurrent infections without pus and leukocytosis, but no albinism or giant granules. E. Deficiency of adenosine deaminase causing lymphocyte dysfunction. Describes severe combined immunodeficiency, SD. Presents with severe viral, bacterial, and fungal infections, chronic diarrhea, and failure to thrive, but no albinism or neutrophil granules. Key takeaways for USMLE: CHS defective lysosomal trafficking due to LYST gene mutation. Key findings: partial albinism, recurrent infections, neuropathy, bleeding tendency. Peripheral blood smear, giant granules and neutrophils, can progress to HLH, accelerated phase. Treatment: bone marrow transplant, BMT. Would you like a question on CG?